In this episode, we dive into the fascinating world of artificial intelligence in medicine for a discussion with Dr. Saurabh Johri. Saurabh is the chief scientist at Babylon Health, which delivers and develops a range of different digital health products around the world. It can be quite a technical discussion at times, but we have tried to keep jargon to a minimum where we can, and we start off with a bit of a broad discussion of what exactly we mean by AI, and this reveals, I think, just how broad the term actually is. We talk about what sort of data can be used by machine learning models and why overall it's a really exciting prospect in medicine for both patients and doctors alike. Now, lots of our discussion surrounds Babylon's triage system or symptom checker. This touches on how it's been built, how it's been tested, what its aims are overall, and the use of AI systems in medicine is certainly not without its controversy, and particularly towards the end we spend quite a lot of time discussing concerns surrounding safety, bias, and ensuring that AI systems actually serve all populations and demographics effectively around the world. So I hope that you enjoy the discussion, and as ever, do get in touch with any questions or feedback. We'd love to hear from you. So Sarah, thanks so much for joining us today. It's great to be with you, if only remotely.
Yeah, likewise.
Lots of the work that you do is centered around artificial intelligence. And I think just to set the ground for this, I was wondering, how does this differ from our traditional views of an algorithm or a flowchart or other, I guess, computer or algorithm-driven healthcare decision-making, which we've had for quite a long time?
There's a distinction to be made between, first of all, AI is such a broad term. It's a really large umbrella term. There's distinctions which can be made throughout as you make different definitions of what AI is. I think broadly speaking, your question is how does it differ from traditional computer programs which might be implemented to do kind of standard tasks such as operating spreadsheets, etc. I think the real difference as people think of it today is the type of program which you described previously is, one thinks about how to construct or how to perform a certain task, and then the programmer would write a set of kind of logical rules to try and encode that outcome which they're trying to achieve. Typically, it's a set of statements in your program that says, if X, then do Y, etc. So a bunch of controls which gives you this kind of logical mechanism for arriving at your objective. AI is slightly different, and I'm very conscious of that term AI. It's a really overloaded term. But I think in the context of this discussion and the context of where we're at now in terms of AI more generally, people think about AI and they think about it synonymously with machine learning. Of course, AI is not just machine learning. There are other aspects to it, but machine learning is really the heart of. We've seen a lot of recent successes, and when we see things such as AI in healthcare in the media or the applications of AI to self-driving cars, oftentimes it is machine learning. And so in these systems, what you typically have is you have your model, which is automatically learned from the data. So it's also kind of important to differentiate what we mean by models versus algorithms. So your model is the representation of your kind of data generating process. So in other words, you've observed some data in the real world and you want to uncover this model which has created that data. And then an algorithm is the set of techniques which you use to construct that model. So that's just a bit of a differentiation between the two. So I think that's roughly speaking the difference when we think about AI as synonymous with machine learning.
Indeed, I think AI can be bounded around, you're absolutely right, a lot in the media, perhaps in cases where it's not necessarily AI. We should be kind of wary of that distinction and perhaps some of the hype that people are trying to add to it in some cases. Following on from this, one thing that has become more and more apparent now is that we can use all sorts of different types of data to input into these models. And I was wondering, could you tell me a bit about that and how perhaps that's changed and what we mean by data sets here?
Yes, there has been a number of really significant advances in machine learning. And those significant advances in machine learning have given us this perception that we have systems which are truly intelligent. But really, the key point is that, and it does relate quite strictly to the data, is the ability to leverage large volumes of high dimensional data. And this is really what has been a game changer. So a number of methodological advances which has created have created algorithms which allow us to leverage that high-dimensional, high-volume data. That's the first thing. Secondly, there's a lot of computational power available now. So, I could be sitting here in the next hour, for example, spinning up lots of high-performance GPUs, graphics processor units, to train my machine learning models on high-dimensional data. And then the third aspect of it is that you have frameworks which are allowing software developers to do the work which typically, going back 15, 20 years ago, even shorter than that, maybe 10 years ago, still would have required a fairly high level sophistication in terms of, an understanding of mathematics. So understanding linear algebra, understanding, calculus, to kind of think about how to train your models. So that's the kind of advancement side of it. And why I mention that is that the data which we can now leverage for machine learning models are high volume, high dimensions. So high dimensional data, what I'm talking about really is things such as image data. So lots of pixels packed into a single file, large volumes of images. For example, we can now, train machine learning models to understand X-ray images which might have been stored on some internal hospital database. Those types of data sets we wouldn't have been able to leverage those data in the past. Typically in the past, we were kind of limited to, smaller, lower dimensional data. So it might just be a kind of table, and that table has a bunch of features in it with some outcome which we're trying to predict. And that's why, and there are kind of still merits to that approach, particularly when we think about kind of some of the imperatives which we want for AI in healthcare in particular. We can talk about that later. Different types of data. So we can leverage electronic health record data, which is high dimensional. There's lots of it, and there's lots of different features or variables in those data sets. There are real and simulated versions of those electronic health records. Going on to some kind of more sophisticated recent advances, which I can talk on later, is the ability to take off-the-shelf machine learning models, particularly for things such as natural language understanding. So here we've had a number of really significant advances even in the last 2 years, and those advances now let us take pre-trained machine learning models which have been trained on just enormous volumes of data, and what they allow us to do is fine-tune those language models, those machine learning models for language understanding, fine-tune them. They might have been trained on, for example, all of Wikipedia, and so that model has a lot of information in it. Now, you can fine-tune those models with healthcare data as well, if you wanted to. So you're getting a lot of leverage from pre-trained models, and you can now apply that into the healthcare domain. And then probably more pertinent in the context of healthcare is the ability to leverage and incorporate other digital biomarkers. For example, there's lots of digital biomarkers which you can get from devices, cell phones, wearable devices, etc. But then also things such as genetic sequence data. So we can now incorporate the insights from genetic sequence data into machine learning models, which typically functioned using population health data. So that's a really kind of powerful set of approaches where you can start to look at the impact of so-called SNP-based chips, which gives you markers for various kind of phenotypes, and those can be incorporated into population-based algorithms. These are particularly good for looking at things such as polygenic risk scores. So there are certain sets of conditions which are, which those SNP chips give you a lot of information about. And that starts to get into this realm of kind of personalized medicine. Some of this is information which we are using ourselves at Babylon. We've kind of paused a little bit on incorporation of genetic sequence data because of our attention and focus on the COVID crisis right now. But that's something which we intend to pick up at a later stage, working in collaboration with partners, universities and institutes in the United States.
I think that's really interesting, this idea that now we're being able to combine more and more data sources, and data sources that actually perhaps people thought were incompatible almost with computer models, such as complicated electronic health records with rather than numbers or individual patient characteristics like blood pressure. You've actually got doctor's notes that can be deciphered in this way. How standardized do these data need to be for these models to use them, I guess is my question here. If you're looking, say, across an entire country.
It's a good question. Ideally, as standardized as possible. But you work in healthcare, and I've worked in healthcare for some time. These data sets are sparse, they are patchy. You don't always have consistent coding standards, particularly when we look at healthcare records from the United States, for example. Obviously, there's a different system in operation there where the incentives to code are based on reimbursements. And in some senses, the incentive to code, for example, in the UK is also based on some other set of incentives. So ideally, what we would like is patient records which contain everything. So what we would like is structured medical records. In reality, what we have is medical records which have some coding, but there's a lot of free text in those medical records. And so that's really why we can apply some of the techniques which we've developed, but also techniques which we leverage from other places to help structure those medical records. So of course, you can't do much when the medical record only contains, so if you have a patient, so let's say it's my medical record, and if I'm having a consultation with a doctor and that doctor's literally only coded one item, so let's say, so I happen to have asthma, so let's just say, mild asthma. So let's just say now that doctor has a consultation with me and then just notes mild asthma without context of any other parts of the consultation. That's really meaningless. But even in cases where we do have unstructured information about the patient, then we can structure that medical record using natural language understanding, natural language processing techniques to pick out the entities of that medical record which might be pertinent. So really what we want is not just asthma, but we want the symptoms of mild asthma. We want the kind of medications which the patient, in this case me, might have been on. We might want other information about my demographics, and so on and so forth. And when you think about not just one patient record, but hundreds of thousands, potentially millions, as we look across the globe, you can start to see where machine learning and AI techniques might be really impactful to better understand patients and kind of create machine learning models. Of course, one of the implications here is how representative are those patient records when you're trying to apply these types of systems globally. So, of course, in the United Kingdom, one would imagine, given it's the NHS, we have better healthcare records than, let's say, another country. I won't give an example, but there are obviously going to be disparities in that. And so what we want is our AI-driven digital health products to serve patients regardless of their location. And so that is a major consideration for us as we build these systems.
In fact, I'd like to touch upon something that you mentioned very fleetingly a few minutes ago. And it's this idea that I'm quite curious about, of simulated electronic health records. Could you tell me a bit about those?
Yeah. Simulation kind of sounds as if it's a kind of mysterious technique, but actually it's relatively simple. What it really requires is that you have an underlying model which represents the data which you're trying to simulate. So let's say, for example, that I've got a set of healthcare records, an electronic health record data set for, let's say, a population in London. If I can learn a model which faithfully represents that population, that means that I can actually then simulate from that model and try a bunch of different assumptions and say, well, look, this population in London is different to the population which I actually want to kind of model. So what would I do? Then I would just say, look, the prevalence of, let's say, diabetes in this population is different to the population which I want to assess through my simulation. So what I'll do is I'll simulate from this model, but just assume that the prevalence of diabetes is slightly different. And so when you look at those simulations, then you see that the prevalence of diabetes or some other set of conditions is reflecting the population which you want to, because you've automatically injected your own notion of prevalence into that model. That's an example of the use of simulated data sets.
We always hear this kind of term in medicine. If you hear hooves, think horses, not zebras. Yeah. But actually, sometimes your definition of a horse is going to be very different in different regions.
The type of model which we use under the hood is something known as a probabilistic graphical model. And really that is, for those in the kind of medical domain, they will have known for some time that these types of systems have been used for a long time in the form of Bayesian networks. So that is the type of system that we use. We of course extend that quite significantly. One of the challenges with those systems is actually how do you perform what is known as inference on those models. So these are models which represent medicine in our sense. In our case, a simple abstraction of our model is a three-layer network, a three-layer model essentially, which says risk factors are associated with diseases and diseases are causal for symptoms. So if you as a clinician were to look at that, you would actually understand what's going on in that model. So that's a really nice feature of that model. And then the hard part is how to do inference on that model. That is a fundamental difficulty of doing inference or asking questions of that model. It's a computationally very challenging problem, one which we've overcome, and we've got kind of published research which shows how to overcome that. But to your question specifically about how do we adapt these models, I've heard that term a number of times. I really like it. We obviously work with clinicians, quite a lot at Babylon in the development of our models, and that's what they always say to us. They give us these kind of medical sayings, and they're really fun. So I've heard the one about zebras and horses before. So how do we adapt our models? Because it's a generative model, and it's a generative model which is both expert and data driven. So we can learn that model from data, but also we can leverage subject matter expert opinion. So we have a lot of clinicians who we work with, not just clinicians, but epidemiologists and public health professionals who can help us to adapt these models to local settings. So I gave you the kind of description of that model as a three-layer model. So these models are age and gender stratified. So they kind of reflect disease burden in different age groups and in different genders. Also, they've been localized per region or per territory in which we operate. So if a patient presents with fever and vomiting in the UK, that's obviously going to be a very different likelihood of disease than if that patient was presenting with those set of symptoms in Rwanda or in Thailand or Malaysia, where we also have our products available. So we get that data, just to answer your question, we get that data from various different sources. One is through partnerships with large-scale public health providers. We have a partnership with the Institute of Health Metrics in Seattle, who provide global surveys of kind of disease burden. So we partner with those guys. As I mentioned, we also have teams of epidemiologists working at Babylon who go through the literature and ensure that the data going into our models are meticulously kind of researched, so that that data is not just there's an association between this risk factor and this disease. Does that association account for any confounding factors which might also be mentioned in the papers? So we do a lot of hard work in thinking about how to construct those models.
I was wondering, could we chat a bit about this use of these systems in triaging and exactly what this means?
One of our current products is this triage product, and I've touched upon the model as in the abstract, and I can go into a little bit more detail about this now. So the model which does the triage, we work off of the assumption that to triage, we should know the likely causes of the patient's symptoms. So a patient presents with some set of symptoms, and what we are trying to do, and this is fundamentally the task of inference in our model, is uncover the hidden entity. The hidden entity in our case is the disease layer of our model. And so the patient presents with some set of symptoms or risk factors. We might have some patient history about the individual, so we might know that they've used our service 6 months ago, and at that time they told us they had a family history of diabetes. Well, if that's accurate, that's not going to change. Family history of diabetes is a family history, that's immutable. And so that will remain constant. So that is already evidence into our system. Then a patient might tell us, 6 months down, well, at the present time, which is 6 months from their previous consultation, that they have, shortness of breath, or they might have some thirst or whatever. And that is, again, evidence into our model. So what's happening in the background is that the model is updating its beliefs, much in the same way that a doctor constructs a differential diagnosis. What they are doing is looking at the patient. They are saying, this patient, so in my case, I'm a male between the ages of 35 and 45, reasonably good condition, but I'm presenting with symptoms X, Y, and Z. Prior to the presentation of those symptoms, the model or the doctor has this background or underlying belief about the individual, and that's based off of the prevalence of diseases for somebody who looks like me, age and gender-wise. And so evidence into the model is just it's evidence used to update the underlying probability distribution over all diseases in our model. So in the classic case where I present with fever, vomiting, and some set of other conditions which might be indicative of a disease, it's not just indicative of one disease, it's indicative of many diseases. And so the task of triage is to say, okay, given a differential, which is this set of disease probabilities, a ranked list of disease probabilities, how do we then triage that individual based off of the likely disease, but also the harmfulness of the diseases in that differential? And so that is really, as we go beyond what was typically a Bayesian network, the Bayesian network part of the model just gives you the distribution of diseases as a ranked list for your differential. The task now is to say, given that differential, what is the best course of action for that individual? Should they stay at home? Should they go to a pharmacist? Should they see a GP within 6 hours or in 2 weeks? Or should they go to the emergency room, the emergency department, either get there very quick, get there themselves, call an ambulance, whatever it might be? And really what we're doing is we're performing some calculations to say, well, look, in the case where you have a very high confidence that this patient has, for example, appendicitis, if I told that patient to stay at home, that's a really poor outcome for that individual. But on the other hand, if I told that patient who has appendicitis to go to the emergency department, that's a really good outcome. So if you think about those different categories of triage outcome, there are essentially 6 or so. And if you think about the differential, essentially what you have is a matrix or a table, which you're trying to kind of get the optimal value for that patient. And so that is really the process of triaging. Of course, this is a purely probabilistic system. And what we know is that, so if this was a purely probabilistic system, which was completely faithfully representing the reasoning process that a doctor uses, we would be fine. The probabilistic system is a rational system, but we also know that human decision-making is not always rational, particularly healthcare decision-making is not always rational. So we know from speaking to doctors that actually there are certain clusters of symptoms which are indicative of something significant happening. So if we get clusters of those symptoms, then actually we don't go into that probabilistic system. We just say, no, this is too dangerous for us to factor. You should speak to a doctor or go to the emergency room. So there's that aspect of it to consider as well.
And I think a really important point to make here is that none of these systems are ever going to make perfect decisions in terms of 100% accuracy in that sense. And actually we shouldn't expect them to in a complex healthcare system, and B, medicine doesn't function like that. And also it's also about balancing out the probabilities. Again, your false positives and false negatives. There could be a situation in which you say actually the price of sending or telling 1 million people to stay at home because they haven't got something can be balanced by a few people who stay at home and are perhaps harmed by that, and that's a fine thing to do.
Yeah, well. Absolutely, and that's exactly what we do. We're always looking at we define this, and I always get this the wrong way around. I used to think about this in terms of sensitivity and specificity when I was working in purely in healthcare, but now when I'm working in the machine learning and statistics domain, I always think about precision and recall, and I always forget how to map those two terms to sensitivity and specificity. We can look offline, I guess, but that's essentially they they are trying to optimize for this kind of trade-off between false positives and false negatives. In our case, what we're trying to really ensure is a low number of false negatives. In other words, we don't want to tell a patient they don't have a disease when they do have it. So what we do, we evaluate the performance of our models prior to releasing them into the product, into the wild. But we also have this continual feedback mechanism where we have continual surveillance of the performance of these models. And that surveillance is done by clinicians. Some of it can be automated as well, but we rely heavily on our clinicians.
And another question I had leading on from this is, when we're talking about large data sets driving this triage decision, what happens? Medicine advances quite quickly and things can change quite rapidly. A single disease can be divided into two diseases and recognized actually as a syndrome. How do artificial intelligence models respond to these quite rapid changes that could lead to guideline changes within, say, 3 months without necessarily the data sets that underlie them being updated to reflect our new medical understanding?
Yeah, that's a really good question. So there are kind of two parts to that question. When the guidelines are updated, those updated guidelines are also generally updated in the underlying medical ontologies. So an ontology is a structured representation of knowledge. In the case of medicine, it's a structured representation of medical knowledge. So ontologies in medicine are familiar to many of us, many of your listeners, I'm sure, things such as ICD-10, SNOMED, READ, RX norm, and these types of things. And so one would expect that actually when you have updated guidelines, that those updates are also going to filter through to the underlying ontologies. There's no guarantee that they're kind of running in complete parallel. So that's one aspect of it. The second part of it is there are certain things which we can do in the model. So we can ask different types of questions to the model. I'm not a clinician, and I'm hoping that I'm answering your question suitably enough. But in the case where a certain set of symptoms might be indicative of, not just one disease, but a cluster of diseases, there are different types of questions which we can ask to the model. And the model will respond accordingly, reflecting the underlying ontology if it's been updated. But then that updated ontology will also trigger the updated ontology will also trigger the idea that the model is not up to date with that underlying ontology. And so it will ask the clinicians to go and acquire additional information, either from the published medical literature, or in the case that there is not enough data, what we will do is then fall back to providing a safe triage outcome. So it's really incumbent upon us, or really a high requirement for us, to ensure that the product is safe. And so if we don't have sufficient updated clinical information, then we will ensure that the triage outcome is safe, at least. I guess actually one thing to add to that is that's actually a great benefit of using AI systems in healthcare. Is it's almost like a single software update and everyone gets access to that benefit of updated knowledge. Whereas in healthcare, if you were going to rely on all clinicians updating their knowledge about some new guideline or some new recommendation, multiple agents have to act independently. Whereas here in an AI system, one agent is updated and then all users are impacted.
And so certainly we see clear examples of practice changing very quickly, but also we see examples of practice definitely lagging behind the published research in this case. This is one way in which you anticipate AI actually integrating with the work done by clinicians. To what extent have you studied the way in which these systems work, not necessarily just in isolation, but actually in combination with how clinicians work? Because it's one thing measuring the outcome given by AI, but also it's quite important that if we're talking about the overall aims of this, which is, we talk about kind of clinical endpoints of improving people's quality of life and lifespan, really it is how clinicians interact with it that can dictate a large part of that. So how do you see this then?
So I think when we first started out on our journey at Babylon, we often thought about pure accuracy. And of course, that's always going to be important in terms of clinicians, patients, regulators being comfortable with the AI
driven product which we put out into the open. But increasingly, the penny hasn't dropped or anything. We always knew this to be the case, but our first priority was to improve accuracy. But then, and now what we're doing as we've kind of built the product organization within Babylon, we have a lot of direct testing of these systems by clinicians. So getting into kind of putting my product hat on, as we think about Babylon as an organization, we have these kind of digital health products which we developed, and I've given you examples of one of them, certainly, which is this triage diagnostic product. So we have here a team, and that team includes engineers, it includes epidemiologists, it includes machine learning scientists, but it also includes clinicians. And so, when we're releasing these products, the clinicians are constantly informing the product teams, the engineers, yeah, this would be a useful feature. Okay, if we believe it to be a useful feature, that's our hypothesis. Now, let's test that feature as it performs alongside clinicians. So examples of such features might be, okay, so if you imagine a kind of, again, with my product hat on, a patient journey. So you might have a system where I, as a user, have some set of symptoms, and I have a conversation with the chatbots, and I'm providing my kind of evidence into the system to say, I've got fever, vomiting, and whatever other symptoms, and I get the most likely cause of my symptoms, and then I get a triage outcome. That information is all stored as structured text. Now, the triage outcome might be book an appointment with your GP. So I book an appointment with my GP, and all of this information goes up front to the GP. And so now when the GP is waiting to have this conversation with me, they have all of this information up front. So rather than going through the kind of mundane task of performing a history, what they can then do is to say, well, actually the machine learning model, the AI system, should have asked questions, A, B, and C, which it didn't ask. Or actually, look, it's done a pretty good job. I'm going to mark this model as a good kind of flow, for example. But in the cases where it could be improved, they say, well, we've got all this information up front, that's very useful. And basically I agree with the system, but I'm just going to ask a few other questions to get a real sense check of what's going on. So that's one example. Another example is, a really kind of very nice use case that we use is automatic summarization of patient consultations. So we've got these kind of patient notes, and we can apply these natural language processing techniques to summarize patient clinical histories into kind of much more shortened versions of those consultation notes. So those are just simple examples. As we go into, maybe this is overly complex to talk about, but what we think about now in our context at Babylon is providing our digital health products in the context of what is known as value-based care. And so for some of your audience, this might be familiar, but essentially what we're trying to do is to achieve the so-called triple aims. And these are first of all, we distinguish value-based care from the model which has been in operation in some parts of the world where we have a fee-for-service model. And really the incentives are slightly misaligned in terms of providing value to the patient in terms of improving health outcomes. So what we're looking to do with our digital health products is to achieve three things, really. That's to improve the health of the population, to improve the health outcomes of the population. It's to improve the patient's experience of healthcare, and that includes measures such as the quality of the information provided to the user. So we might evaluate that through things such as patient-reported outcome measures. And then thirdly, we're looking to reduce the per capita cost of healthcare. And so in that system, on the one hand, when we think about applying machine learning and artificial intelligence in the context of healthcare, it's not a nice to have anymore. This is an absolute essential. If we are going to look after the health of populations, we really need to understand where the highest risk is for those individuals in the population. So we do that through the use of machine learning. So let's say we take our population, some random location, let's just call it London for the sake of convenience. We take 100,000 patients in population in part of London, and we say, where is the highest risk? Who are the patients of highest risk? How can we serve those patients best? And given that we know that they're the highest risk patients, how do we adapt the rest of our products throughout the whole product to service those patients best? And so this is really a partnership between the insights which we get from these machine learning models and also the clinical care provided to those patients. So I hope that kind of makes a little bit of sense.
So with this, how do we go about, you mentioned this idea of perhaps going beyond just looking at accuracy for, despite it being very important, for judging the success of the systems that you're designing. How do you go about measuring and testing whether you've achieved these three different strands of goals actually out in the real world?
The health outcomes, that is clinical outcomes. So in the case of
diabetes, for example, I always use this example. It's one that I don't know particularly well, but it's one which our teams often talk about. So there we would look at the impacts of our interventions. So we might have products which are providing care plans to patients with diabetes. And so now let's say that we have an arm of the population who has access to these care plans and an arm of the population who doesn't. They might be exposed to some other guidelines. Then essentially what we're trying to do is to compare the impact of those interventions and looking at the impact of the clinical outcome. The clinical outcome here might be HbA1c measurements, for example. So that's the kind of impact at a high level when we think about improving the health outcomes of the population. The second one is through of course, health outcomes are not just clinical health outcomes. They're also patient-reported outcome, can also be assessed through patient-reported outcome measures. So we might want to look for how informed did the patients feel about their healthcare, how engaged were they with their healthcare. And so this is equally important and increasingly understood, particularly in terms of, essentially what we're trying to do is to, provide information to the patient and that information should be used to guide their kind of adherence to the healthcare plan. And for that, we need patients to adhere to the healthcare plan. And so a lot of this is about ensuring that the products are created in such a way as that they're engaging. Because without an engaging product, as much as we've designed machine learning models and highly performant and accurate machine learning models, unless a user is engaging and giving us constant feedback about whether they are adhering to the care plan, it's going to be very difficult to understand the impact of the intervention on those individuals. So we spend a lot of time thinking about the behavioral science of compliance to healthcare information. Of course, we also need to ensure that actually we ensure that the products are tailored not just from the kind of medical side but also culturally. So now if we're providing healthcare plans to populations in London, those are going to be vastly different to healthcare plans, let's say in Kigali or in Missouri or somewhere like that. So you probably get a sense of the scale of the operation. It's not just localizing the machine learning models or the kind of insights from those machine learning models. It's localizing language, it's localizing, and so of course the machine learning models have to understand different languages. It's also understanding cultural considerations of the territory in which we're operating. So there's a lot that goes into it, and that's precisely why we have a large number of people at Babylon now.
And are these interventions, when you're testing them, randomized? Because that's certainly one thing that does come up time and time again when we're talking about digital health, which is the idea that perhaps the people who we're providing digital health to are not necessarily representative of the population as a whole. They're normally younger, they're normally more tech savvy. How careful do you have to be about this when assessing a product? Because a product that looks at, say, diabetic outcomes in a population of predominantly younger patients or more affluent patients that's quite a significant confounding variable if you're comparing it against another population.
Yeah, I mean that's if we're going to do a randomized study, then of course we take into account the sample size of the population, and the sample size, of course, would be dependent on the various kind of predictors which we are trying to assess. So all of that's the kind of beauty of doing these kind of randomized control trials, is that you're accounting, given the large sample sizes, you're accounting for those confounding variables. So in an RCT setting,
we're kind of accounting for that. Even if you're looking at, let's say, affluent populations in London, and one arm of the population takes the intervention and the other arm is given the control arm, you're still looking at the impact of the intervention, even if that population is relatively homogeneous. So what we're trying to do is understand the impact of the intervention on similar populations. But of course, what we can also do is look at wider populations and run observational studies. So these are, when we don't have, when we don't have the ability to run randomized control trials, what we're able to do is to look at observational data and use a lot of the new techniques which we're developing, new techniques in so-called causal inference, which are used quite heavily in biostatistics and epidemiology to control for those confounding variables. And so those are also quite powerful. Of course, RCTs are the gold standard, but where we don't have access to data or we can't run a randomized control because the intervention is implausible or in some cases unethical, then we can get a lot of these learnings from observational data.
For this, what sort of cases would it be implausible to run an RCT then?
Well, let me give you an example of it's a standard one, but it might be not implausible, but I'll give you an example of an unethical one. So if now, let's say you wanted to look for the impact of smoking on lung cancer, you couldn't randomly force one half of the population to smoke, but you could observe,
yeah, of course,
so that's what I mean by in cases where it's unethical. Likewise, there's going to be cases, I can't think of one off the top of my head, which is implausible, but there will be plenty of examples.
Although that's perhaps a slightly different example to sorts of products that you're using here, where we're obviously talking about introducing something new. I kind of accept that example, but for example, if you're looking at a diabetic care plan or access to a triaging system, do you think randomization should be possible in all those cases and should actually be used then?
No. In the case of care plans, it absolutely should be used. But when we're starting to look at, introducing things such as wearable devices, and the wearable devices giving us data which might be responsible for augmenting the care plan. So that's an example where not everyone will have access to devices which are giving us this additional information. So that might be implausible, for example, to look at the impact of an intervention in one part of the population which has this kind of this digital phenotyping information and one arm which doesn't. But what we can do is we can account for that missing feature and run an observational study. So that's kind of an example of it. In the case of the diabetic care plans, yes, in that example, yes, we will be running randomized trials, and that's actually work which we're about to kick off. We've got two studies which we're about to kick off. One is actually, I can't mention it, it's undergoing review right now, but that study is to look at the impact of wearable devices and their predictive capacity for detecting unplanned healthcare events. So I was actually in a meeting this morning precisely about that with our collaborators. And so I'm really excited about that study. I'm really excited about that one. I think it will be one of the first ones of its type to answer those types of questions on a real population as well.
We've been talking a lot about potentially how AI could streamline how people go through care and increase the efficiency of it. But do you think there are certain things that actually artificial intelligence and your systems could improve on clinical care? And if so, what areas are of most promise rather than just supporting the standards that we currently have?
I'm trying not to be too hyperbolic about AI and machine learning. We are where we are. We have, really highly performant systems. And right now those systems should really kind of augment clinicians. And what we've seen, where AI systems have been hugely impactful is when you pair those systems up with humans. So you see that, for example, in kind of competitions where AI and chess systems outperform humans all the time, or it's kind of known as, these are kind of known as, I think they're known as centaur systems. But likewise, in healthcare, for the time being, I think we should be thinking about AI systems empowering clinicians. That's the first kind of aspect of it. Secondly, I think there has already been kind of demonstrations of where we can use AI not independently of clinicians, but you can quite easily imagine points in time where AI systems are being used independently. And these are, for example, to learn optimal, a good example is learning optimal treatment guidelines, or learning optimal treatment strategies. And there are examples of this in the published literature. So there's kind of teams at Imperial looking at using deep reinforcement learning to understand optimal treatment strategies for sepsis patients, for example. So that's a really good, that's a really nice use case applied to medicine. But more generally, as we think going forward, as people and healthcare systems start to see the benefit of really collecting good quality data, structuring that data, and as kind of natural language processing and machine learning techniques become more advanced to allow us to structure unstructured clinical records, then you can quickly start to, imagine a place in which insights from these machine learning systems, the kind of inferences and insights coming from these machine learning systems start to kind of feel, getting to that sense of what we believe AI is now, is performing some sort of magic. It's not, in fact, but actually, when we think about it, machine learning systems operating on increasingly vast amounts of data, making connections to the types of data sets which I referred to previously. Human cognition is what it is. It's not going to, I don't imagine it's going to increase at the same rates that artificial intelligence machine learning systems are. So, if we think about where we are now and sort of the exponential growth in terms of performance of machine learning systems in line with the growth of data sets and increasingly sophisticated mechanisms for machine learning, it's very hard to say where we'll get to, but you can kind of imagine.
It's hard to exactly put our finger on, if you look at the amount of change that's happened in the last 10 years or 20 years, exactly where we're going to be in 5 or 10 years' time. And I was wondering too, how do we, when using such systems, it's often said that AI can be a bit of a black box, and there have been concerns around issues of bias, for example, in it, and the fact that we can't really fact check the processes by which AI is going through to make its decisions in the way that we probably could better do in normal clinical practice. How much of a concern do you think this is, particularly from a bias perspective, actually identifying errors in systems?
Yeah, I mean, it is a concern. And so the kind of machine learning models which we develop at Babylon are less prone to these issues of this kind of black box issue. So I kind of differentiated, I think I did at the start, these kind of class of generative models which we have, which are driven both by data and experts. A kind of nice feature of those models is that they are interpretable and explainable, and therefore less subject to bias. But of course, we do use kind of purely discriminative models, which are based on deep learning systems, and those are theoretically possible. It is theoretically possible that there is bias in those systems. Fortunately for us, what we do is that we don't use those systems to perform decisions. What we use those systems for, these kind of deep learning systems for natural language understanding and natural language processing, we use those systems to process data offline. So to do the structuring of medical records from unstructured records. So yes, when we refer to the importance of causal assumptions, that is a key feature of or a key mechanism through which we can debias machine learning models. So we can ask so-called kind of counterfactual explanations of our machine learning systems to say, okay, so we've got some outcome here. What if we controlled for a particular feature in our data set? Would we still have got the outcome which we're seeing? So if we controlled for gender, would we still see the outcome given here? If we controlled for race, would we still see that outcome? It is a huge issue, but then it's kind of important to somewhat distinguish between having an interpretable model and explainable model. There has been some advances in this kind of understanding of the outcomes of deep learning systems through so-called, there's been a kind of explosion in this era of explainable AI. So this is essentially having machine learning models explain other machine learning models post facto. And so those are, pretty performance, but of course there's still, you're layering one machine learning model on top of another. Ideally, what we would like to do for some domains anyway, and healthcare is one of those domains, we would like to favor interpretable models, which gives you explainability as a side effect. Generally speaking, these interpretable models are models which encode some structural knowledge of the domain in which you're operating, healthcare in our case. Ideally, that structural knowledge can be encoded with causal assumptions baked in. And there's something to be said about how the sparsity of these models. So if you look at these generative models and the structure of those models, generally speaking, if you look at them, they are much less dense than a deep neural network. And so there's something to be said about the sparsity of those of the representation of that model, which gives the interpretability, and that's probably tied to the cognitive performance of humans, who are have this kind of upper bound of the number of concepts which humans can reason about. So it's well known from the kind of cognitive science literature that it's kind of 7 plus or minus 2 kind of concepts which can be reasoned about.
Yeah, we're certainly the number of nodes in a deep neural network can get up to enormous levels in the end with
billions.
Yeah. So from this, I guess another question I had, which ties in with, I guess, what we've been talking about, kind of real world usage of these systems, which is actually ensuring that they're used in the context in which they were designed to be used and in which they've been tested in as well. To what extent we should be careful actually of, I think it's been termed kind of out of context use of AI.
I think what you're referring to is the generalizability of machine learning systems and AI systems. So we know and this again goes back to this. I hope this doesn't sound as if I'm beating up on these kind of deep learning systems. I'm a big fan of them, but I'm a big fan of them in the appropriate context. So what we know about these systems is that they are relatively brittle. They perform very well on. Another way of saying this is that they perform poorly on out of distribution data. So if you typically kind of train your machine learning model based on some data set and you separate that data set into testing or training and testing data. So let's just say you've got, hundreds of thousands of medical records from a particular hospital. You kind of create your model using training data, and you hold out some of that data, let's say 20% of that data, to test that model on. So that's all within distribution. But what if you were now to take that model and apply it in another setting? So I've developed my first machine learning model in London. Now let's say I apply that same model in, let's say Birmingham. How does it perform? We know that the models are somewhat brittle in the sense of their performance on out of distribution data. And so there's been kind of recent examples of that, which is there's kind of some fun examples of this in terms of, I can send you the link to the paper afterwards, but there was an example in the last couple of weeks, which I saw where, we had a deep learning system which was diagnosing from X-rays the likelihood of COVID-19. And performance was reasonably good within data from the same training and test split. But then when we went out of distribution and we looked at another data set, actually what we were predicting with really high confidence was a cat. So it's completely unrelated. So that's kind of a fun example, but that's fun, but actually it kind of highlights the importance of building AI systems for healthcare, and in particular with a certain set of principles attached to them.
Particularly in, for example, with COVID-19, if a model has been fed quite a lot of different pieces of data and you're not entirely sure which one it's using, it is potentially true that some of the information that it's using is fantastically good at predicting something in a setting. For example, if you took somebody's length of hospital stay, I'm sure that correlates with COVID-19 in some sense. But if you actually get a patient in front of you and you're looking at an X-ray, not retrospectively, then actually you don't have that length of stay there. Working out which pieces of information it's used that an AI system is using, something I've seen in some places has started to be used as well to almost get past a little bit of the opacity.
That's a really good example where you're not factoring in the time dependence, for example, the time dependence information. But of course, in the case where we're looking at predicting COVID-19 from an X-ray image, the task has a limited scope, and so we shouldn't expect these machine learning systems to perform miracles. They should be used in the context for which they've been designed, and potentially they should be used as features for a larger scale model of the patient, for example, which is what a doctor might do. A doctor, whether I get the terminology right, so you might have a kind of a technician looking at the X-ray, then you might have the patient going to another part of the hospital, but eventually you'll come back to that one doctor who's in control of who's responsible for their care. And so in the same way, in a machine learning model which is looking purely at an X-ray shouldn't be responsible for the final diagnosis on a single piece of evidence, right? So these systems have come a long way and they're extremely powerful, but we should be cognizant that they are not magical systems. And so I think there's a lot of there's a long way to go in terms of how we incorporate these systems into clinical practice. And I think we're starting to see that. And I think we're also starting to see developers of these systems becoming increasingly cognizant of the need to evaluate these systems, not just internally within their own organizations, but having them evaluated externally. We're certainly cognizant of that, and that's something which we're looking to do as well.
Yeah, and going back to, for example, looking at an X-ray, that's certainly been some of the criticism of some of the tests of clinicians versus AI working on imaging, that actually it's not really a representative test if you're just giving a clinician an image and no background, an AI an image and no background, because in reality, actually, gold standard care in that case is a clinician looking at the image, for example, with colleagues as well, and with patient information and patient history, and maybe results of tests from that patient. And I think that's kind of perhaps quite a key point, that we're looking at testing real world usage rather than slightly artificial usage, particularly in the later stages of these developments.
Absolutely. I think that just, again, just kind of echoes the point that I was making, and one which was taken from your original question.
We've been talking for quite a long time, so yeah, that's probably all we've got time for today. But yeah, thanks so much for chatting with me. We covered so much ground.
Yeah.
And it was an absolute pleasure.
Good. Well, yeah, it's a pleasure for me as well. Covered a lot. Hope I didn't speak too much. And,
absolutely not. No.
Hopefully your audience finds the conversation enjoyable and informative.
Thanks for listening to the Pager podcast. If you've enjoyed it, do leave us a review, share it with a friend, and come back to listen to our other episodes. As ever, we'd love to hear what you think. You can reach us at Pager Podcast on Instagram and Twitter, or email us at pagerpodcast@gmail.com. Bye for now.